All right, seeing that it is 5 o'clock, let's go ahead and call this meeting to order. This is the April 24th, 2025 regular board meeting for the Kittitas County Public Hospital District Number 1. On the agenda, I just want to add to executive session personnel in addition to litigation. Other than that, any other changes or I'll make a motion?
Motion to approve the agenda as amended.
Second. Oh.
Motion by Matt, second by Bob. Any further discussion? All in favor, say aye.
Aye.
I too will vote aye. No one's opposed. That motion passes. If you had a chance to review the consent agenda, I will entertain a motion when ready. Motion by Erica. Second by Terry. Any further discussion? All in favor, say aye.
Aye.
I too will vote aye. No one is opposed. That motion passes. We are on to number 4, public comment and announcements. So does anyone here wish to make any sort of public comment to the board of the hospital district? Give me your thoughts.
I'll give you a thought.
There we go.
DJ Goldsmith, I'm the fire chief for Kittitas Valley Fire and Rescue. And I just want to let the board know that we've been in conversations with Jason and team about the transfers that is an issue. We're working some stuff internally and working with your team to streamline that. We've got some processes. I greatly appreciate the work that we've already done. We'll continue to improve that process, but want to let you know it's a foresight for Kittitas Valley Fire and Rescue and how we can continue to keep serving you as our call volumes, like your volumes are going through the roof. So
Thank you very much. Appreciate that. Anyone else like to speak or comment on any topic that is related to the board? All right, hearing none, we will move on to presentation. So tonight we have the department spotlight, which is the lab. Anyone want to introduce that?
Sure, absolutely. It's really wonderful that we're doing this now because this is the Medical Lab Professional Appreciation Week. So we're really happy to spotlight them. And as you know, Katie Bellotti is the director, and she has Alana and Sammy and one of our former lab professionals joining us. So go ahead, ladies.
The next slide. That silver thing right there. Okay.
Unless I could do it for you, just it'll work.
Let me see if it, okay.
Very good.
All right, so I'm Alana. I'm the chemistry lead in the department.
Sammy, I'm the point of care and phlebotomy lead.
Our director, Katie, so I'm gonna be presenting. So as you know, about 70% of the medical decisions are based on lab results. So it's very important that we are very accurate and precise in our ability to deliver these results. And this is our brand new instrument. It's taken a couple years, but we are fully all together. So it's about 2 years, and we now have four new instruments that are installed. They're all connected to an automation line now. So everything is gone from manual to automated for the most part, which alleviates a lot of the bottlenecks that we currently had before. We have some new in-house testing we're going to talk about, and then looking forward, we want to talk about optimizing our workflow and meeting the growing community needs.
We also would like to take the time to thank everyone for our newly updated space. It's been a very large improvement compared to our previous space. It has allowed for us to continue to streamline our workflows, add a couple more workbenches, as well as allow for the automation line that we're going to talk about here shortly. We would not be able to add that in our previous space. And we also wanted to touch on our patient-facing areas that we've gotten a lot of positive feedback from the public. It's allowed us to create more of a calm and quiet environment for patients while they're getting their blood drawn, which is really important since it's more separated from the hustle and bustle of the lab previously. So thank you.
So I'd like to start by kind of outlining what it looks like in our lab. So we have this is the automation piece, and then we have our 2 chemistry instruments, our larger immuno, and all of these are connected. And then we have a backup benchtop here as well that's new. I want to highlight that we're not your average rural healthcare clinic hospital. There are a lot of travelers that we get that are just amazed by our robust amount of testing that we offer here. And just the amount of technology is huge compared to other places. And it's just great to be able to support our community with such a high level of technology and assay.
Alana, do you want questions as you go or at the very end? Or do you not want questions at all, maybe?
Questions are fine. If you want to stop me and ask me anything,
I
that
was getting up there, it says track system. Is that an item of itself or is that just summarizing the boxes right below?
so this is kind of a layout, so it's kind of like a blueprint of it. So these are actually connected. And so our fit is the piece, so we load everything here. And then,
Is this a Bechtel system? What's the name of it? Okay.
yeah. And so it connects here to the line, and then the line will take it to the instruments and then take.
Physically moving the samples.
Yeah.
down the line?
Mhm. And then this is just our little guy on the side. So the two instruments in the top right-hand side, I'm kind of highlighting where we're going here with these. We have these are our general chemistry instruments, and a huge improvement from what we had previously. We only had one instrument and it did all of our chemistries and immunoassay all in one. Now redundancy. So if it were to go down for any reason, or if we were doing maintenance on it, it would be unavailable for that time frame. And so now, because we have redundancy, we're able to have one down and one up constantly. So we don't lose that turnaround time, which is huge, because previously when it went down towards the end of its life, I think the one was about 7 or 8 years old, it was having a lot of issues and needing service a lot, and we'd have to send samples to Yakima. So we're increasing that turnaround time by about an hour at minimum. So being able to have this redundancy is incredible. Currently, we have 51 photometric tests that are performed in-house on this instrument. It does have a higher, like other offerings for esoteric testing that we're currently not doing, but that doesn't mean it's the stopping point. It's been very reliable for us so far. It's we've had it for a little over a year, and we've had about a handful of calls. So for service calls, for whatever the reason may be. It has a really high throughput, can do 800 tests per hour. And for all the tests, it averages about 8.5 minutes per test. So that's pretty impressive. As an example, I put a CMP and a comp metabolic panel and a basic metabolic panel. So it does it in 10 to 12 minutes. And then our lactic acid is 11 minutes. And I wanted to highlight this one because it's used for the sepsis protocol. And so meeting that CMS quality measure is important to us, making sure we can get that out in time. And we also have redundancy now in that we can, if one goes down, once again, we have the other one. So previously we would have a different test methodology for the backup, so they wouldn't correlate as well and you couldn't trend them. So being able to use the same test can trend a lot better for the patient. And
Previously, how many tests per hour did the old machine do?
I don't know what that throughput was.
It was less?
It was definitely less. Yeah. So and then this one's also separate. So you have two instruments performing. So the automation line prioritizes where it decides this one's busy, so I'm going to run here. So it prioritizes stat samples, and it can say, oh, this is a stat, you're running 5, so I'm going to take you to here, and then I'll take you to here. So it really can prioritize.
Is that telling someone to physically move that stuff or is it happening
Happens all on the automation.
automatically? It's
Yep.
automatically knowing how to grab the samples and put them where they need to go.
And this one, both of them actually, well, this one more so does a really good job with small volumes of samples, which becomes extremely important when you have pediatric patients or when you have elderly patients or just people that are really hard to draw, because the last thing they want is to be poked in another. So being able to run off what you can get, granted it's a quality sample, is huge. This is the last big guy on the end. So it's our newest addition. It's our DXI 9000. It was the most advanced technology in laboratory medicine. It uses chemiluminescence technology, and it has the highest throughput of any analyzer on the market, immunoassay analyzer on the market. It was recently released from the FDA within the last couple of years, so it's really good technology. And really advanced. It can do 450 tests per hour. And currently we are running 18 tests in-house. There are quite a few that are still in FDA approval because it's so new. So as they start becoming released, we have the ability to bring those on as well. It has a good precision or a high precision and accuracy as well as sensitivity. And this is important for those things like troponin because we need to be able to read those at a very minimal level. A lot of facilities are still running the old conventional assay of troponin, which doesn't, it has a cutoff that's not readable. So I kind of can't really see it that well, but on this graph here, this is comparing the high sensitivity to the conventional. So this line right here is the conventional. And then this line down here is where it can detect with the high sensitivity. And this is 0 hours, 1 hour, and 3 hour. And so at 1 hour, you can see it's detecting cardiac damage. Whereas the old one, you actually couldn't detect it until about 12 hours. So we're able to detect that cardiac damage at a much earlier time frame. Another cool thing about this instrument is it uses tips instead of probes. And the tips allow for, eliminates carryover. So you're not introducing the probe into the same thing. So it opens the window to a lot of infectious disease where you don't want any carryover, like the HIV and the hepatitis testing. We are currently not running any of that in-house, but there's some still in the FDA that once it gets approved that we'll be able to bring some of that testing back in-house. This is our last benchtop analyzer. It is the same technology as the DXi 9000. This one's been around for many years, so it's pretty robust. And the DXi 9000 uses a different substrate, so it's able to do the test about 5 minutes faster. So that's where you get that 12-minute for the troponin. This is a little bit longer, but it's a really good backup for us. And it can do about 50 to 100 tests per hour, not the same throughput, but it's also designed for a smaller facility. It's not designed for the high volume. It has been used for our backup numerous times now when we need it, and that allows us to keep that testing in-house. We no longer have to send it to Yakima. We have a backup for troponin that can be trended because it's the same reagent. Previously, we didn't have that. And we run 4 in-house tests right now, and that allows us to maintain that competency so that the quality is not compromised when we do need to use it. Did you have any questions about it?
I was gonna ask in general, what's the schedule of the lab? Are you 24 hours a day or?
Yep.
7 days a week then?
All the time.
All the
And
time.
what capacity are we currently typically running at?
Like for staffing?
No, because one thing I want to see how soon before I have to expand again, but secondarily, room to grow have people send their stuff here because we have capacity for it. So I'm trying to understand, the machine itself, and then secondarily staffing obviously plays into it too, but what sort of, level are we running at currently?
We don't come close to the amount that it can
So we
do.
can do a lot more.
Oh, yes.
We got a lot of room to grow.
Yes.
Okay.
It has a huge throughput. It can do, I don't know if did I talk about? No, we're talking about that next.
Okay.
Okay, I'll just go with that. So this is our automation piece. So this is kind of showing what we can do now. At first we load the samples on the instrument and it has a pre-analytical check. So it looks at the tube cap color. It looks at the volume in the tube and looks at the label to know what test it needs to run. Once it decides if all that's acceptable and the tube type for the test and all that information, it will decide if it needs to centrifuge it or needs to just take it to the instrument. So if it centrifuges it, pulls it out of the centrifuge, it will sort it based on priority. It will decap the samples and it will take it to the instruments. This is our DXE 700 and there's little carriers and it just samples directly from that line. And then it goes around to the next instrument if it needs to, and then it goes right back to the final storage here. Those are what our storage, we have about 4 of those. And I mean, we try to keep them every 2 hours. So if we filled all of these up every 2 hours, and we don't even come close to that.
Yeah.
The storage that we have right now, if we leave the samples on in storage, it can retrieve those samples for any additional add-ons from like the emergency room, any reflex testing or any dilutions that it needs to do. So it automatically does that and there's no manual intervention.
You mean an order comes through and it knows to go get that sample and run it? Nobody has to tell it to do that?
It will print off and then we can merge it to the original accession. It will find that tube, pull it from storage, put it back on and take it down.
The machine is doing.
Machine is doing it, yes.
And then prior to this enormous upgrade, these steps in this cycle, were those all done by human hands?
Yes, we were actually just gonna talk about that. That was, no, you're okay, you're okay.
This just means we're flowing.
Yes, this is wonderful. We actually, a great example we have with this, with having to do all of these steps, as Alana mentioned, we're all annual tech time. So a great example would be someone who's on night shift. We have one tech and one lab assistant. That tech could get pulled away for a number of reasons from, let's say, the chemistry workstation, where that centrifuge was our main bottleneck before, because you're having to put the sample into the centrifuge, take it out, process it, take it and load it onto the analyzer. Now, and if they get pulled away for a stat blood transfusion or a positive blood culture workup, that can possibly affect that turnaround time because they're not standing there by the centrifuge to take it and put it on the analyzer. Whereas now, because it's able to do all of these things, the lab assistant or even the phlebotomist who's on staff can take the tube and load it on the analyzer themselves. The tech can keep doing what they're doing with that stat blood transfusion or the positive blood culture, and turnaround time is the same, consistent across the board.
Is there any blood tests and things like that done in our Upper County? And then that blood is brought down to be tested in the lab, so that way the patient doesn't have to drive all the way down here to get it. And then with this new machine, once the test is done, the results goes back to the doctor in the Upper County, correct?
Yes, yeah.
Yeah, so we save a lot of people from having to drive down to get their tests done down here, correct?
Yes.
Okay, thank you.
Yeah, and an added benefit, touching on that, would be all of our clinic drop-offs. It also has the ability to, it's interfaced with our LIS, so Cerner, and we are not having to sit through and manually log in every single tube like previous, which saves a lot of time. We can take all of those tubes from the clinic batches, load it onto those racks, and that magical robot knows exactly what to do with them. It sorts them to the certain departments, saves a lot of time. And possible error if you accidentally don't log in a sample, that saves a lot. It's very consistent.
And speaking of consistent turnaround times and quality measures, to highlight one, we are right now averaging we're about 33 minutes for troponins. I wanted to highlight specifically the turnaround time for troponin. So this was our go live. Initially, our centrifuge was broken and it didn't work for a couple weeks. So we were doing everything manually still. And then as we're getting used to the workflow, you can see we're kind of like bouncing up and down for the turnaround times. But towards the end of it, you can see we're starting to like streamline and get it down to a really good consistent turnaround time where it's not being held up by the centrifuge or anything like that. So you can see, and the throughput it's designed to process up to 4,000 samples a day. So that's quite significant over what we're currently doing.
I just have a quick question that I think is following up on something John asked. So we're getting all these numbers about how much it can process. And I know you said that it hasn't even got close, but do you have any sort of ballpark numbers on how, on average, of course, I imagine it bounces up and down, but on average, how many samples are being processed in a given week, in a given day? Again, recognizing that there's fluctuation, I just want to get some sense of numbers.
That number can vary a lot.
Yeah.
I know that just based on our lab encounters, every single day we average about 150 to 170 a day. One of those patients could have about 5 tubes or 2 tubes. So it could be 300 plus a day. That's almost all of them are being loaded onto the machine, whether it's actually taking those because they're chemistry tests to the analyzers or is being utilized as a sorting tool to sort to different departments. So it kind of varies.
Right.
We don't have an exact number,
Of
but
course.
yeah.
But like a heavy day for you,
Mhm.
where you just say, wow, we really got.
Yeah.
planned there is 300 plus.
300 plus, possibly 400 samples.
Right.
That could be urine, anything for different departments like hematology or chemistry, but yeah.
Okay, all right,
Mhm.
thank you.
Yeah, of course.
With all this automation, what's the risk of it? The computer making a mistake, assigning the sample to a wrong person or something like that? Is it, you don't notice any,
We have not encountered any mistakes.
so far we're at zero? at least?
Yes.
No.
Yes, it can have, the glitches that we experience would be whether it doesn't know what to do with the tube,
Okay.
not affecting patient care result at all, maybe possibly delaying it further if we're having to help it out with telling it where it needs to go, but that's few and far
So it
between.
doesn't know, it doesn't guess.
Right,
Okay.
exactly,
Understood.
exactly. It has a special rack
Yeah,
that says,
we
I don't
have a
know
rack
what to do
for
with
that.
it. Yeah.
No, it questions everything that it does not, like, is not for sure, like, this is exactly, or if the sample's like too short or or like hemolyzed or anything, like, it'll be like, nope.
And does that help people learn about these samples? I mean, you can see what its limits are, so you know.
Yeah.
To the best, you know, like, oh, if I put that in, it's not gonna work, so we need to adjust it now before.
Yes,
Yeah.
yes. We've actually have continued to optimize our workflow, which is kind of that chart she was showing about the troponins. It's partially why we're slowly starting to steady out. Because you have those rare occasions that stuff like that happens, or the centrifuge isn't working, or we have come to learn lots of different workarounds to troubleshoot. And I think a lot of us on staff have learned a lot of troubleshooting skills, which is actually really advantageous to us too, and the patients.
Some of the additions we've made to our test menu. We have reproductive hormones now that we didn't used to have on site. Most of these can be performed in less than an hour. So this kind of leads to women's health and potentially them expanding and growing in the future to bring on specialty fertility clinics or services that need that immediate turnaround time. We've changed BNP back to pro BNP, and the quantitative rheumatoid factor we've added to our test menu. Previously we just did qualitative, so we can now quantitate that. And then another significant addition is fentanyl we added to urine drug screens. This one is huge because we didn't realize that, at least for the feedback I'm getting, we didn't realize fentanyl was so big in our community. So being able to see those patients that come in that didn't even know they had fentanyl in their system we're able to treat them and counsel them and overall help them figure out, more than we could have before. So that's a big one.
We've also been able to intervene on some addicted mother babies and get help for them.
And looking forward, obviously we talked about a little bit about expanding the test menu as they become FDA approved for some of the 9,000 tests. We'd like to bring those on. And we'd like to also optimize our workflow, which we're working on all the time to figure out the best way to use what we have. We'd like to collaborate more with other departments. I've been talking to Cody and the ED a little bit about our turnaround times and what they're seeing and what we see and how we can work together to make it better for our patients if they see things that we need to improve on or vice versa. Supporting our growing needs of our community's healthcare is definitely at the top of our list, and that's what we come here to do. And Katie's gonna talk about outreach a little bit now.
Yeah, so you guys have created us an amazing niche by allowing us the redundancy in the lab with both the chemistry analyzers, the hematology analyzers, and microbiology. Going forward, as Alana said, we are not your regular rural access hospital. We have on average 150, 175 encounters a day. When we're really busy, I've seen the past the 200 mark. And that is strictly with outpatient lab encounters. That doesn't count the inpatients and the ER patients that we've been taking care of. A third of those encounters are from outside facilities, whether it's coming from the west side, whether it's coming from Yakima, or even right here in Kittitas with clinics and hospitals that we're not interfaced with. So we're manually putting in all of that information. So we've been looking at some outreach LISs or EMRs that will directly connect or allow outside facilities to access via browser to directly order their stuff that will drop into our EMR, allow us to access those labs so that we can just activate them without having to manually enter them. It'll decrease orders getting lost. It'll decrease tests getting ordered incorrectly, and they'll be able to access their results immediately in their computers. They're not going to be waiting for those faxes to come through that hopefully will go to the right fax number. So this outreach LIS will communicate directly with clinics, private providers. And, you know, when we get the notice of the surrounding communities that what an amazing job we're doing, we'll get them coming in too. All the orders will go into your outreach EMR and then into Cerner, which got by our lab analyzers, and it'll make everybody happy because they're able to immediately access their orders and their results. Currently, what our workflow is, we have people like Yakima Endocrinology, Prestige, Sweetest Hospital, and Issaquah, CHCW, which are faxing us their orders. They make it, they don't make it. They're zooming around out there in some cloud because it doesn't know where to go. Some of them come through from what we hear on the phones. A lot of them don't, which is making everybody unhappy. It costs us a lot of front end time, both on phones, putting in, trying to discuss with the providers why we haven't gotten them, whether we're taking verbal orders or manually entering our test orders into the computer system. It's causing exhaustion and fatigue across all areas. But with this outreach LIS that we've been researching, because a majority of our encounters are, or not a majority, I'm sorry, about a third of our encounters are from outside providers. It will help increase both the number of tests that are being utilized on chemistry analyzer and decrease the fatigue and the wear on the employees.
Would an interface like this be accessible to small providers, the ones who are still using paper requisitions and triplicate, that sort of?
Yeah.
Is it just they get on a browser, they don't have to have any proprietary software or anything to engage?
Correct. So depending on the options you go with, these are just the ones I've looked at currently. I'm still researching, but I've seen where you can actually interface your two EMRs so they can order on their end and it'll go on our end. And I've seen where you can use a browser form and they can access our test menu on the browser, order what they need, and it'll cross to us, and then they can pull those results out of that. This is how we plan to make it even more profitable in the future. Oh, did I miss? Sorry.
Laboratory.
Any more questions?
So, the cost, so we introduced these new items, these new options. How do we price them? Because usually we do the contracts with with the insurance companies ahead of time. Are these already on the menu of the contract? We eventually we're gonna get them, or how are we pricing these things for them?
So we look across pricing, they have a tool that looks at market pricing in the Northwest compares to Washington hospital average, compares to quick access hospitals on average. And we set at a median rate. Or sometimes if that tool doesn't work great, I'll reach out and try to get a rough idea of the cost to do the test. Or if it's a test that we have to refer out, then we get the cost for that lab out. handling those things and stuff, so.
And the insurance companies, so far as we add things in, there's been no pushback from insurance companies if somebody has insurance.
Yeah, no more pushback than
Than
anything
normal?
else. Yeah.
Okay. And then
I still don't pay it all.
and I think I have a question probably for Rhonda. Just remind me or confirm for me. I'm fairly confident we have some sort of service contract for this. Is that accurate? Seems like a very complicated device.
We have a 7-year service contract in place.
Okay, so during that period, we can control expenses. We know what it's gonna cost to keep this thing running. and so
Yeah.
forth. Okay, excellent.
The first year's usually free. on
Included.
service Contract.
Yeah.
But as you move forward, yeah.
Yeah, any other questions?
I got the
I
opportunity.
don't think till we say.
I had the opportunity to tour. It's just a beautiful system. If you walk through our lab 7, 8 years ago and you walk through it now, it's an unrecognizable place. And to watch it working is like, when I was in there, I was thinking of like Jurassic Park. Rotating that egg. And then all of a sudden you just want to do all these things. It's very impressive to watch. And if you, have the opportunity to go back there with them and see it work, it's impressive.
Feel free to stop.
And there was,
Yeah.
there's thousands of slots for tests and see our few in there. So there's a lot of opportunity.
Well,
for-
it'd definitely be nice as we stabilize and, some marketing campaign, let people know this exists. So let's take advantage of
Yeah,
that.
just educating the community that we have this knowledge. It's impressive for a facility of our capacity to have such high quality.
Yeah, I think you said it earlier, this ain't no normal rural hospital.
When
Yeah.
we
It's a
tour
t-shirt.
physicians through, for recruiting and stuff through here or the ORs or the medical arts center, they're wowed.
Well, when you take them through, make
You're
sure,
an independent critical access hospital.
but make sure you say, this is our small lab.
Yeah, they're just getting started.
see the big one.
Right, right.
Yeah, well, they are making this look easy, but I can't tell you the amount of work and the hours that they have put in to make this function and to bring it online. And it has been over a year-long project that they have just
Yeah.
heart and soul.
Alana and
into.
Sammy have done absolutely amazing getting this analyzer
There's a
installed. and
lot of
running.
build and interfacing, let me tell you.
Well, just know we really do appreciate it. It was great to see what you're doing here today, and I'm sure all of us at some point will take advantage of come down and see it in person because we want to see the Jurassic
Yeah.
Park egg.
We can't.
Good. All right, so any other questions then? Otherwise-
Well, I would
Oh,
just like
go
to
ahead.
say happy Medical Laboratory Professionals Week.
Thank you.
We can't. claim.
Thank you very much. And you don't have to stay for any more of the meeting if you don't want to.
Thank you for joining too, Bonnie. It's good seeing you.
Yes.
Thanks, Bonnie.
If you want, it doesn't help.
Okay, let's all clap now.
Oh. Thank you for having us. Thank you.
Thank you, Sammy. Thanks, Alana.
All right, so moving on to reports and dashboard. First, we have Mandy Olson, Chief Quality Officer. Mandy.
So my report starts on page 13. Don't really have anything to add. We're going to talk about one measure in particular, but if you have questions about my report or the dashboard, I'd love to take these first.
Questions for Mandy?
We got a lot done at the QI council meeting, which she summarizes at the top there.
I've got a couple questions. You have time for?
Yeah.
So your CQO work paragraph, we get a first person that says, I was able to pass my Just Culture certification exam.
Yep.
Is that referring to yourself?
That's me.
Anything you can share? What is that? What?
Well, Janine actually did it also, and
Uh-huh.
she passed hers sooner than I did. So Just Culture is, a concept I think we talked about a couple of board meetings ago, and it's integral for your patient safety culture. So how are we holding each other accountable to the work we do and being fair in that? So holding people responsible for the choices they make, but also making sure that the system is set up in a way that doesn't set people up to fail or to make mistakes or to reward bad behavior. So that's what Just Culture certification was about. It's with the Just Culture company.
that David Marks wrote the book Whack-A-Mole, founded, and he has a whole algorithm about how you analyze situations to ensure that you have a just culture in your workplace. So we're working on that still this year as we look at part of the employer of choice copy that Janine has. And some work we'll be doing into next year, looking at what we have in place to support our leaders and staff. I don't know, what else should I say about that?
Just sort of hardwiring, high reliability, accountability, integrity. In decision-making process, asking, you focus on the outcome, obviously, but we're really more interested in what led to the outcome. Root cause analysis, all that. So we're just sort of hardwiring that into our leadership development as well as part of the body. So it's pretty exciting.
I should say, I mean, this isn't anything really new to KVH either. When I started in my role, I think Rhonda kind of kicked it off. But in 2014, we engaged with the Just Culture Company and created our own Just Culture algorithm, or a way to respond, that incorporated David Marks' Just Culture algorithm with James Reason's incident decision tree. And we still have those tools and people use them, but we have a lot of new people. We've grown a ton. And how are we making sure, like Janine said, that that's hardwired and really accessible and usable for all of our staff and leaders?
Excellent, thank you.
Yeah.
Your first bullet point in your quality division updates at the top of 14.
Yes.
Do you note that we're easily going to double last year's cases? Is that a good thing or a bad thing?
That has to do with compliance. Yeah, that Susie's gonna talk about. And I know on a quality perspective, yes, we are always interested in increasing reporting because it shows people feel safe and they're bringing up concerns. And hopefully by identifying things before they become a problem. But yes, Susie's talk about it more now.
Yeah, I can do it now. So we had a total of privacy compliance and amendments combined last year of 41 cases, and we're at about 36 right now. So I just think we will easily double that. And it is because people are more comfortable reporting. That was our goal the last 2 years, was to create that culture within KVH that people have that comfort zone. So I think it's working, and yeah, it's good.
How do you create the culture? Is it by people report and everything goes smooth and they spread the word? I reported and feel safe to report, or?
Yeah, it's been that, and then also just getting the information out to staff.
Okay.
So that it's accessible. They're not having to dig for that information. So they've got the compliance poster accessible. They've got a compliance board now in the hallway, and hopefully they're seeing the compliance, officer name and privacy officer name just about everywhere, and that number is always there. So yeah, and excellent support through the compliance committee. So
Thank you. To make sure that there's not retaliation, which is against the law, but also that's a piece of it is, people feel like they're not going to be punished for reporting things.
Yeah.
And then feedback to reporters, or coming back to them and reporting what you and that's a piece of it too.
Because sometimes it's anonymous, but if it's not anonymous, you get them feedback.
yeah,
I think just socializing it too, so we are comfortable talking about privacy and compliance. We're also comfortable referring people to report to privacy and compliance, and we talk about like, oh, probably should have reported that, and don't take it offensively or anything. One of us will do that and follow up, and Susie's been wonderful to work with. A real asset to KVH, and Susie just making her presence around too. She's, I think, got multiple offices, and well, now you kind of landed now, but she was for a while working out of a mobile office that she wheeled around with her. So just making her presence around and people being comfortable with the process and working with Susie.
Excellent. Any other questions for her? Do you want to talk about the dashboard or what?
Yeah. I mean, we're going to talk about one measure in particular briefly, but if you have questions about any of the, I didn't have anything else to add from what was in my report. But if there's questions about specific measures.
Questions about specific measures? I will ask one then. page 17, middle row, critical lab value, timely follow-up.
We're gonna talk about.
All right, so let's save that for your full talk then.
Okay. Well, so one of the things, the critical lab value timely follow-up, this measure in particular is looking at nursing. When they are reported a critical lab value to them, do they then report that value to the provider within 15 minutes? So, there are requirements we have when we have critical lab values, which those parameters we set up, we decide with medical staff what's critical, and then that's set up in the system, and it's flagged. The lab has to notify someone within 30 minutes is what our policy says. And then if they notify an RN, someone that's not the provider, that person needs to then notify the provider and document that. So that's what this is measuring. We just recently looked at it though, again, because it's not improving the way we expect it to. And just one of the things we recently identified was that part of our sampling method, I think, is flawed in that we were looking at the failures is what we're sampling. So we think that this data is skewed to it's kind of cherry picking the bad cases. And we need to revisit that measure and look at how we're capturing that sample and what we want to measure, what we want to standardize too, as far as documentation, because that's part of the issue we're seeing is people are documenting in lots of different places. The report we pull looks in one place and then we have to do manual audits to look in other places. So Deb's been working with her leadership about standardization and then who follows up on that. So we're pausing this measure in this moment while we reevaluate the standards and the measurement. But kind of a short measure talk today, but we found some things out. I don't know if that answered your question you might have.
Anything else for us?
Just that it's under quality. We've got Susie here to talk about the annual compliance report and order plan.
So if you have a copy of this one has page numbers. One of the bonuses of being under quality now. Mandy, read it out.
I knew I might ask for that.
Well, it would have really made my reference sheet fail, so I appreciate that. So compliance highlight, I'll be attending the Compliance Institute next week. And I shouldn't put this out in the universe, but I'm testing for the certified in healthcare privacy compliance certification. So
I think it should do
see how that goes. If you turn to page 8, we have the 2024 work plan review. And most of you, this is the third time.
For just one second, page 8 would be what page in our packet? Does anybody know?
In this, do you have this?
But this is the middle of our packet.
28.
28?
So you should have one at your desk that's
Oh, I
a
should
new
put that
one.
rather than the packet?
Yeah.
Yeah.
Thank you for the.
That's right. So this 2024 work plan review, several of you, this is probably your third time seeing this. I'm not going into a lot of detail on the summary, except that 100% of these items have been addressed and they are ongoing. Does anyone have any questions on that review? If we jump to the compliance effectiveness assessment on page 11, this was last year's, and all of these objectives have also been addressed. Moving on to the assessment for 2025 on page 13. This year, we are focusing on auditing and monitoring. The last couple of years, auditing and monitoring have been done on a case-by-case basis. It should be done regularly. As Jeff so eloquently put it, we paused the regularly scheduled audits for changes in compliance privacy leadership transition. So I like that. And we're resuming it this year. And I think everybody received some sort of notification that those are starting in June
to share with your team. The focus on that audit is going to be staff members accessing their own medical records. So we'll begin there.
That's frowned upon, or that's okay?
Frowned upon.
Frowned upon.
Yeah. Let's see. Yeah, so that leads me to my compliance thank yous. Mandy Olson for taking compliance and privacy in.
It's still yours, but I'll support.
We're under nice roof. The compliance committee and the continued support by its members. We have excellent turnout at the compliance committee meetings. Unless people are out on a conference, we have very good representation. Jennifer, welcome to the compliance committee. If you don't know you're part of it, I'll get you some more information there next week. Terry Clark, our compliance board representative. Terry is always positive, very supportive, and at all of our meetings. I really appreciate you.
Yeah, well, I think the compliance meeting has been very good because you've been overseeing all the things that need to be compliance. And we've been meeting 100% of them, because we know that you're doing very good compliance. So, yeah, so thank you for being such a great compliance person.
Thanks, Terry. And then I'd like to also thank Jason for his constant support with keeping KVH Lab compliant, very supportive. And, you know, this program is only as good as you all. That's, I can't do it alone, so thank you very much. So going to the 2025 work plan forecast for board approval on page 12. Backtracking a little bit. So I'll turn this over for board approval, unless anybody has any questions.
The motion to approve.
Do you want to move to approve this because
Yeah, I would move to approve this, the 2024 work plan forecast. Because I know our board will,
I need that date. It's
what?
You said 2024, I need 2025.
2025, I'm sorry, because I was looking at the page before. So 2025 work plan forecast. I move to 100% do a compliant view on it and vote everybody.
I second.
Motion by Terry, second by Matt. Any further discussion? Hearing none, all in favor, say aye.
Aye.
I too will vote aye. No one is opposed. That motion passes. Anything else for us?
That's it.
Thank you very much.
Yeah, thank you for.
Thank you, Suzie.
Yeah.
I learn a lot from Suzie through every one of these or other just learning opportunities. She's sent a lot of materials out for us to learn from, and there's a lot of things to be compliant on.
Yeah.
And
So many confusing.
it goes back to even that reporting incidences and things, you know, it's the executive committee talked through things like, oh, that's something we should report. Consult with Suzie and work through these unique circumstances.
That's a good way to put it.
Yeah.
Good luck on your
Thank you,
chance.
Susie.
Thank you. Thank you, yeah.
Anything else? Drew? Okay.
can we say break a leg in healthcare or no?
Right.
Right, so moving on to Chief Executive Officer, Jason Adler, what do you have for us?
Yeah, thank you. My report is on page 37. I don't have too much other to add on that, but just go through a couple of exciting things coming up. May 1st, we will be rolling out and going live with Rural Physician Group's Compass program. And that allows us access to some teleconsults with patients or inpatients or observation patients admitted to our hospital for infectious disease, cardiology, and pulmonology services. And it's through Rural Physicians Group, which is who we contract with for our hospitalist group. So the physicians that that we contract with them for are used to this product and it's part of their service. So it's should be a very streamlined and exciting thing to offer to our patient or community. Just a little bit, or a significantly higher level of access to care for these unique patients that might need consult with a specialist. And the way it works is the specialist will remote in through a cart And they will have a one-on-one consult with the patient through a art system. They have a stethoscope, you can hear them, talk to them. It's pretty impressive technology that they're rolling out with. We're the second hospital to go live with it, other than 4 hospitals that they demoed it with and worked out all the kinks. So far, everything's going pretty good. You have anything to add on it?
It's very exciting. There's a lot of opportunity here.
Deb, do you have anything you want from, maybe feedback from Jeff and Cody on it?
No, I think you spoke to it well. I mean, I don't know how much we're using it yet, but it's.
Doesn't go live till May 1st.
Oh, yeah, sorry.
Any minute now.
I was distracted. Yeah, we're not using it yet.
Yeah.
Thank goodness.
Training as
Yeah,
we speak.
no, the training went really well and I know people are excited about it for sure.
It'll be offered 24/7 once it starts.
24/7.
And we're actually pretty lucky about that because not all the hospitals that they're looking at future, they're gonna do 24/7, they're gonna do limited hours. But we already signed 24/7, so I'm excited about that. For May 10 coverage.
Home care hospice is, they got a new clinical director, Jackie Morris, so just really excited to welcome her to the team and be working with the program there to continue to serve our patients and community better or further. And just want to give a shout out to Debbie Kelly, who is our interim clinical director that came in from retirement from Virginia Mason. She retired out of the west side from Virginia Mason with a very long career, and somehow I ended up with her phone number. And she was happy to come in and help. She already moved to Salem and for Ellensburg. Yeah, so pretty cool to have that resource in our backyard and just a wonderful nurse leader to work with. And I've gained a lot of insights from her too. So thank you for allowing us to have Debbie Kelly. Cardiologist, so we just added a second, potentially third, but a second general cardiology PA provider. This one's a PA, Joel Reiner. He started on Monday. If you get the opportunity to meet him, shake hands with him, I think you'll see, it's just gonna be wonderful blend with our culture. And he's worked with Dr. Nyack in the past, so they're a wonderful seamless team. They have a lot of exciting things to be bringing to our community. One of which is, they started a telehealth program out of Wenatchee some years ago. And that's just an opportunity that we have to really reach further into our community through telehealth services in the specialty realm. Anything you want to touch on about Joel and that?
They also brought with them one of their nurses that they're used to working with. Secret's been fantastic. Hopefully that is just the beginning of you guys bringing more great talent to us.
Excellent. Yeah, and that goes with the recruitment retention. Just continue to recruit really good people, good staff, good technology, good facilities. I think this recruits itself that way. Construction, a little bit less going on than prior months because the surgery expansion project is done. We are waiting for occupancy still for the 4th OR, right? Small section.
No, actually, complete from the city. That is complete. We are now to just providing health documentation and everything. There being so many change orders in questions regarding everything. Their departments are having to take a little extra time to go through things, make their approvals.
Really excited to have less construction people in our surgical area than clinical. Yeah, there and surgery comes out as well. Project is on time, or ahead of schedule for the ortho general surgery project. Taking all of Wayne's thunder there on construction stuff. And then legislative stuff, as everybody knows, every day is a new day, so we'll see as budgets and new presidential orders come. So we're still in limbo, you know, our most direct impact potentially is with the SNAP program. We're still in limbo and know what that future holds. It's a $2 million direct impact to us. And then still kind of see as legislation budgets change for what could happen with the insured population. So currently the state and federal government subsidize the health insurance, marketplace health insurance plans pretty significantly to make them more affordable. If those are less subsidized, we'll have more people uninsured, which would obviously increase our uninsured population and our uncompensated care, and probably a lot more seeking insured care financial assistance, which has obviously been expanded greatly in the last few years as well. And then I just included a little chart at the very bottom. There's a survey that was done, and I just thought it was interesting to see really the independent critical access hospitals in Washington compared to the state. So there's still 71% of the hospitals in the state are independent versus national 53%. So it's definitely a way that critical access hospitals are going is less and less independent. So we are unique and we are a very strong independent hospital.
Knowledge or speculation to offer about the median average daily census between Washington and the rest of the nation there that we're at 4 and they're at 3.
Yeah, so our average daily census is about 11 to 12 any day. So it is a lot lower on average than our hospital to critical access hospitals, and we're a much larger critical access hospital than the others. So for example, the Rural Collaborative has 28 critical access hospitals in it, and we're the top 3 and neck and neck with the top 3 as far as size and census goes.
Perhaps the rest of the nation is maybe small, represented by smaller organizations.
Yeah.
Okay.
And then I also got the chance to just go speak at the League of Women's Voters, and it was a good experience and just had a lot of positive feedback from the attendants and all the great work and things that we're doing. It's been noticed and they appreciate that, and they look forward to supporting our hospital. Okay. That's all for my report. Goes into a resolution for
Any questions for Jason on his report?
Next page, starting on page 39, we included a resolution for a levy to hospital district number 1. Resolution starts on page 39, and happy to answer any questions that you may have, but otherwise we discussed it at pretty good lengths in the last board meeting, and we had that presentation by Matt Ellsworth. So this is followed from that conversation. And we would target a August 5th levy.
And is that, oh, there it is.
Second.
Motion and a second, quick discussion. So that is considered a special election. That's not just a primary election on that date.
I think the November one is the primary.
November would be. I think
It's a general. November's a general.
Yeah.
August is the primary where any office with more than 2 candidates running has a runoff, and then the top 2 carry on to November. I just want to make sure if we're signing this, the special election, we would be an off-cycle election, but I'm not a lawyer.
This was prepared by our attorney.
Okay. So we're gonna go with it then. Okay. So any other discussion? All right, so all in favor, say aye.
Aye.
I too will vote aye. Anyone opposed? Hearing none, that motion passes.
Thank you. Appreciate it. I think it's a really exciting time for the hospital district to go out there and do this. I think it will help remind the community as well that we are a publicly owned hospital district, and it is all the community's feedback and support represented by our board to keep the momentum going and to keep the services expanding in our hospital, especially looking in the current light of the fiscal issues going on in legislation around healthcare. So anticipate things to only get tighter and tighter.
This is not a rash decision. I mean, we've been thinking about this for years.
A lot of years, yes.
Well, and I think it's crucial that we help public understand that they get direct return on that investment, keeps medical care here in the valley. And again, equipment that is state of the art, be it MRI or lab equipment or whatnot. So hopefully they will understand that, it
Yep.
gives us a safety net to make sure we keep providing these services.
And it's technically a levy lid lift because we do currently have a levy that we receive about $10,000 per year for. So that covers just roughly about 1 minute of our operations.
Very good. Anything else on that? Okay. All right, moving on, then we got, Chief of HR, Janine.
I have my report on page 44. Stats continue to look really good. We have had a reduction in travel utilization, but I did want to call out on page 46, if you look at the spend report through Before Help, you might ask, well, okay, how come we saw a spike in spending but a decrease in utilization? What's the deal with that? And so what I wanted to just make sure everyone understood is the uplift for the platform required legacy contracts that we had with the individual companies to sunset, and then we transferred them on. So as they began to come onto the platform in February, March, that's when we saw kind of an uptick. And but it looks like an uptick in spend. It's not really an increase in expenditure. It's through the platform now and it's just straight out of the jail. The other thing, we have seen a small reduction from in the average bill rate. And then we can sort of begin to kind of monitor who our most prolific suppliers are. We can get just a better handle on our global utilization of travel contracts as a whole. And it's been really eye-opening for Deb and I and Pam Lutz to really kind of look at staff that are utilized in both the travel and per diem contract. So kind of what's going on there. Those were the types of things we just never would have been able to visualize or see before. So now we're having a lot more interactive conversation about the realities of people who are kind of working and have a foot in kind of both camps, so to speak, so we can kind of get a handle on it in real time. So that is exciting work. And then also excited to welcome Amy Bloodworth, who is the new director of cardiopulmonary. So we got 2 new directors in March, which is very exciting. That is, and again, we're still exceeding the national average for candidate hiring experience and well below the national average for turnover rates. The national average, you'll notice actually that'll be on next month's report. It's actually decreased from, according to the American Hospital Association or Nurses Association, it's actually decreased from 20% down to 18% nationally, and we're still well below that. Last year, we ended the year with about a 13% turnover rate, and so far we're on track to actually beat that this year as well. So great.
So is your chart then saying for RNs so far year to date, which I assume would be the end of March, less than 1% turnover in that category? Am I reading that correctly then?
Yeah, we went a couple of months there, January, February, with no loss of full-time or core staff RNs. So we don't count the per diems. We don't include those in our turnover rates, just as our core consistent staff that we look at. But yeah, so I mean, it's kudos to the directors, the managers and directors. I think it's the relationship too with our staffing committee, the work that we do there, just trying to be transparent, involving our staff in our decisions and talking through pain points with them. None of my colleagues have rates like this. So it's kind of fun to brag about, to be honest.
A good call out on the staffing committee. That's been a committee I started going to in September of 2023 because that's when they required the CFO to attend. And it was a pretty painful committee to go through for a while. It's just working through ADOs, which was assignment despite objection. And we're much more forward looking now. And the whole committee is, and this last was a couple of weeks ago. It was a really good, productive meeting. All the staff on board, everybody kind of heading in the right direction. It was very collaborative. People are open talking. Other thing as a comment on the WHSN, kind of a really indirect benefit that we weren't anticipating is the amount of email back and forth and texting back and forth for negotiating for staffing has went down. So our managers would go to an agency to try to get staffing and then negotiate the bills. Yeah, I'll send you one, but I'll charge you $3 more and say, oh, no. So there's a ton of emails back and forth. Now we just get staff. There's no negotiation, there's no emails. It's just through an app. We put that we want a person, right? But you confirm I'm speaking, right? And then they just fill the slot. There's no emails, no negotiation. It's just done. So anytime we can have a few less emails, that's always welcome by our managers. Thank you.
Anything else?
That's it.
Any questions, Virginia? We are on to Wayne, Chief Facility Officer.
I do not have anything in the packet that I can look up. Jason saying everything's pretty simple. I think. So, waiting a couple of things and starting up a couple of new.
We've gained a few parking spots back. Is that,
Yes,
is that helping a little?
a little.
Okay.
We will finish up. Ortho project. in June. So we will gain back about 18. That's something.
A little bit of the parking lot, there's a barrier up right now, you might notice, and we're just repairing some sprinklers in there, right? Sprinkler system.
And that was finished today. So
Oh, nice.
mission.
It was quick.
Anything else for us? Yeah. Any questions for me? Thank you. All right, moving on to operations, Deb Cowan, Chief Nursing Officer.
My report starts on page 51. I don't have a lot to add unless you have questions for continuing basically a lot of what I reported out last time. I don't have a lot of updates unless you have questions. I just wanted to call out one thing. You get a question.
Oh, you get a question first.
I saw you moving.
I have one question. I want to see if anybody else has any questions first. Ready? Go ahead. Let's see if I can remember the question real quick. So under the emergency department, which is Cody's thing, under ED, it says 2 openings left to fill using ENA residency program to fill positions. Plan to start in mid-May. So
Yes.
2 openings left to fill, but they plan to start in mid-May. So I'm confused. Did we fill them or not fill?
Okay, great question.
Okay.
So last time I discussed residency or transition to practice program through the ER. And so because we're buying the program from ENA, which is the Emergency Nurses Association, it's taking us time to get it off the ground. So the positions are not filled per se, but we have 2 people that we want to plug in them once the program's open. So Cody and I met just recently. My experience with new grads is if you don't offer them a position before they graduate or they get their or test for their license, we will lose them.
Okay.
So he's creating a plan to bridge the gap between the time we can get it off the ground and the time that they graduate and or test.
So you're not waiting till they're finished to
No.
show off their skills. You grab them early.
No.
Draft them out of high school.
Right,
Yeah.
right. Actually, I really think middle school or even, but yeah, if I had my way.
Kat, Heather and Kyle have been making the rounds at the middle schools and high
Excellent.
schools. That's
Yeah.
great.
Sorry, is that all your only question?
It will be for now.
Okay, I just wanted to call out, last time I had spoke about SPD and like sterile processing and how there's been a big lift from Dave in that department to elevate practice and raising the bar. And just an example of that, one of his staff members, Natalie Jacobson, she has been chosen to participate to help write the certification test for that specialty. So our little hospital has somebody in our sterile processing who's gonna help with the certification.
Wow.
So I just thought that was really cool. I wanted to share that. That's all I have.
Lord, thank you from the board. That's exciting.
Yeah, that's all Dave. He's done that independently, raised that department to that place. So it's pretty cool.
One other piece I add to it with talking about David with the sterile processing, Dave and Bonnie have been working close together as well to work on our courier service. So they did send out a request for proposal to solicit options for courier services a couple weeks ago. So we are exploring courier services.
Oh, yeah.
Yeah.
Great.
So that's it for your group today. No other questions for Deb? All right, then we will move on to Rhonda, Chief Ancillary Officer.
Yes, my report is on page 53. And I want to really highlight pharmacy. We did receive notice from the Board of Pharmacy that they have accepted our corrective action plan with no revisions. So that's exciting, and it's already, they're working on it with our clinic. So it's great. And then also I wanted to call out Nasser too for how hard he's been working on, really providing excellent customer service to the patients at the bedside. And I think you see that with a note that I have here about Victoria Chong. One of our pharmacists was called to the ED to counsel a patient on the medications they were taking. And that patient was so impressed that he wrote a letter thanking her for doing that. And also to the RN, Jeff Strifling, who was working and actually had called Victoria down. So great teamwork between nursing and pharmacy and just great customer service. That's my only updates.
Questions for Rhonda?
Let's see, you had the Hospital District 2 board retreat.
Yes.
Everything going all right? You're with Hospital District 2, your position in Hospital District 2, you're finding that fulfilling and.
Yeah, it's great. A little more work. We have some changes going on. I think with our marketing, they're wanting to really have a more robust marketing plan. So that's something that I'll be working on. It will take a little bit of time, especially with everything else going on down here because there's so many projects right now. Thank you.
Your home-based primary care, looks unfortunate. You had an eye on APC and then they slipped away and took a job before getting an interview on that.
It was very unfortunate.
Yeah.
So I'm hoping to find out more details from Kat as to where did they go?
Yeah.
What led them away from pursuing us too. So,
Okay.
Yeah.
Let's do that. You have a question, Terry?
Yeah, Rhonda, under the pharmacy, it said we received a really nice letter from a ED patient thanking a pharmacist to go down and talk to the patient. Do we get a lot of requests by doctors and patients in the ED to talk to them about medications?
I think normally they call, on the phone, the physicians or providers will. And it's not real common that the patients want to have a pharmacist actually come down and talk to them, but they will of course do that, as you know, whether or not it's the ED or med-surg CCU, they're happy to go down and have a one-on-one consult. with the patient.
So they don't ever say they won't do it. They always go down and see them face to face if they're
I would
requesting.
like to do that, yeah.
Okay, so NASA's overseeing and making sure that we do that 100%, correct?
If they're requested, yes. Otherwise, the pharmacist participates in the daily rounds.
Right.
And seeing the patients and interacting with them and the whole entire team.
Well, thank you for answering my question.
Yeah, absolutely.
Under clinic admin, security will do a sweep of the MAC building at the end of the business day. Is there some new reason this is occurring? Oh, that's Stacy. I gotta wait till I get Stacy.
We can jump to me
Your block is so small, I didn't realize it was a whole new
I
section.
just a couple call outs on Rhonda before I jump over to Stacy's. I just wanted to shout out again to Nasser and Rhonda, the pharmacy field program that we started a year ago, maybe, is just going really wonderfully. So we have hired 2 more pharmacy techs to go through that pharmacy tech training program. And then we'll be moving internal adult medicine to have the same feature or service as well to their providers. So it really supports our clinical staff so they can continue to see patients versus doing these, being the first point person for managing workflow program. And then just call out Hospital District 2 as we work through our strategy planning, and as DJ's here too, we're trying to see how Medic One can have it in these interfacility transfers as well. So we're working with that board through trying to see if that they can be a part of that, and commend DJ's team for starting a 8:05 daily management call. So currently it's KVH and KVFR have a daily call to see what's going on for the day, be on the same page, and hopefully Medic One can be a part of that collaboration as well. If Medic One can be a part of taking some of these transports.
And what's the challenge of the transports? Is it having crews out of county and we just don't have enough people to go around and it becomes risky for the citizens here? There's no one to go help in that case, so we have to solve this.
Yep, I'll speak to it, and DJ, you're welcome to jump in as well. So having a crew out of the county, so we need them here. They support fire, they support EMS, they support our 911 calls. So when they're out of the county doing a transport from here to the west side of the big ones, because it takes them out of the county for 4 to 5 hours. And then the hardest part is when we have concurrent calls. So as our volumes have increased, so as our concurrent calls. So instead of one crew going out, they'll have 2 crews going out, or potentially even more. So it's very complex as our volumes have increased to maintain that. KVFR is taking about 51% of all of our transports, and then we have other private AMR or fixed wing or helicopter as well that takes the balance as well. Do you want to add anything?
Yeah, it's staffing, right? Just today, twice, I didn't have a single ambulance available. And because all 4 ambulances were engaged in either transfers or 911 calls, which then leaves the rest of the entire Kittitas Valley Fire and Rescue, no fire response or EMS response. So it's really balancing the priorities to get them out. And again, we have standards that we have to meet. We have 8 people on duty. Just for a structure fire requires 12. So I'm already 2/3 of what my staffing level needs to be. And then send and transfer out, I'm half of what that is. We do have volunteers that help out a little bit, but yeah, it's just really staffing in the call volume. And 2 months ago, we were 31% increase in call volume. We're seeing overall this year 18%. We're on track to run over 6,000 calls, which is unprecedented, and about 82% of that are medical. So it's just trying to figure it out. So again, we're trying to do everything we can to partner and again, take care of our citizens at the end of the day.
People that need to be are chatting about this and looking for solutions behind the scenes.
Yeah, very much so. We're having conversations here. I'm obviously having conversations with my board. Again, it's all funding and what that looks like. It's no secret, we need to increase our staffing, but that comes at a cost. And as it's already been alluded to today with some of the things we're looking at, as Jason mentioned, is the federal funding. We get GMT, which supplements us quite a bit, and then all this insurance then drastically affects my operating budget. I basically 6 people. So if that goes away, which I'm hearing from my counterparts and legislative contacts, that it's 80% chance it's going away. So we've got some big challenges that really affect you all, and that's why I'm here to answer questions and just let you know what we've got going on, because it ultimately, as we are your provider for Hospital District 1, there is possibly some grave effects coming up with all these cuts and what's going on.
Well, if you ever feel the need to give us a presentation or something to get us up to speed on what you do.
I would love to.
Yeah, let's look to get that on the calendar.
Okay.
And I think it'd be very educational for all of us. So
Yeah, appreciate it.
thank you.
Love to.
Yeah, thank you.
And then just last note, Cleveland Therapy, Midtown Depot, we're working with the owner there to consult on some design, and hopefully we'll have a good ask for the next board meeting for signing a lease and some capital to fill that new space with equipment and start serving patients in Upper County in a new way for therapy services. And then with that, it will allow us to expand our primary care services as therapy moves out of the RC clinic. That's all I have.
Anything else from Rhonda's report?
You got it all.
All right, continuing on. Now we're to Chief of Clinic Operations, Stacy Lane.
Yes, I was just gonna talk briefly about the faxes for the month of March for FME. So the way we receive faxes, it's an electronic file, which is nice. So each clinic has their own file. It gives you the ability, if you need to upload it into a medical record, you can do that without having to print. And then we're only printing what we need to do. FME has 2 patient service reps dedicated to, we call it document control. So they handle all the incoming faxes. They handle, once documents are signed by providers, getting them back into the patient chart. And they do a small portion of the outbound faxing. A lot of the EMAs still do their outbound. But I just thought it was interesting to know, 3,000 faxes.
So on the other end, it might start as a piece of paper into a real fax machine or something.
Yes,
On your end, it comes in digitally like a PDF.
yes. Mhm.
If you need it, you then print it out,
Correct.
get a signature, and then you would somehow rescan it to get it back in the electronic system.
Yes, and
What
actually.
year is this?
Yeah, I know. I know when people talk about faxing and do you really need it? There's right now not a good alternative for systems.
Is it privacy? Is it just people need to sign things? It's a quick way to get a signature? or-
It is more sharing information with people outside of your organization. The medical records don't talk to each other. So the only way to get charts to them is fax, or to get information back to us is fax. So it is amazing, and we call it document control because then they also do scanning.
Yeah.
And when we had one person who was just doing this role, we measured scanning by inches. And sometimes it would be 18
Like,
inches a week. Yes,
stack up
height,
this high.
stack up this high. So with
Is
the
it really
two-
thick paper?
No, it's just very thin. So we keep up with it on a regular basis and we can get items into the chart now, usually within 4 days.
Very labor intensive.
Very labor intensive, yes.
And
And
that
it
comes from home health and hospice because we're not on the same electronic record. Cerner didn't have a module for us, so we had to have a different module. So we send Dr. Beard knows, and Dr. Thomas, we send a lot of faxes for signature, for orders, for everything.
And the-
Switched over to Flocera, which let us electronically sign on a different system, but
Yeah.
it does allow us to do that, so we don't have to do as much paper.
It's a lot better.
Does
And then-
Cerner still not have a module then for this?
No.
Okay.
And then it's also dealing with the paperwork, we have disability forms that providers need to sign, social security forms. FMLA paperwork, all of those pieces that aren't a part of Cerner, but yet need to be signed and go into the medical record. And then sent back to the patient so they can disperse them.
All the clinics on the same fax system.
They all go into digital files, yes. Mhm. I'm open for questions.
You mentioned expansion of GYN services and surgeries. Could you just say a little more about that? Is it different kinds of procedures that we can do now, or is it just more?
It really is being able to do GYN surgeries overall. But having only one family practice OB, we pretty much stopped GYN services. Now the way we have rotations created, we do have OBHG provider in the clinic, and their goal is not only to help cover call and do the call for deliveries, but each one has 1 day a week of surgery. So we're starting to see patients come back to us for GYN issues.
Great.
And then also it helps support the ED. A lot of the times the ED had to refer somewhere else because we didn't have a provider available.
Thank you.
I had a couple members of our community complain about telephone calls to the clinic. Are you still overseeing the response to phone calls that are being recorded because no one can answer them?
Mhm.
See how long it takes for them to call them back? Because I had a couple people, 2 people tell me that they left a message and they didn't hear back till the next day. So I still think that there's a little bit of slowness in responding to them. And I was wondering, they asked me whether it would be safe, because they're talking about the family medical center on the 3rd floor of the Medical Arts Center. They wanted to know whether it would be safe for them just to walk up and talk to somebody right there where they would check in for their an appointment or something like that. They could talk to them instead of just calling them on the phone.
We do have some patients that walk in. Some of the challenge with returning phone calls is those are questions that have to go back to providers.
Right.
And providers may be off that day. The team may be off that day, or it may be something that the providers have to research themselves. We do in the clinic now, our phone system for messaging, Zoom. voicemail.
Yeah.
So the clinic manager has it up on her screen and she can see how many voicemails are there. And what it allows us to do then is triage those and respond to those with the highest acuity first, and then work on the other ones. And then from there, we message providers, we message the triage nurses and get other people involved in it. So sometimes it isn't just, we don't have anything to say because the person who needs to answer the question isn't available or is in a room or is doing a procedure, and we've got to wait for them to come back from doing patient care.
So you don't call the patient back and say, the person that would answer this question isn't available till tomorrow before we can get you the answer. So those patients aren't getting any response at all, not even to begin with.
We go both ways, because when we were doing that, we were getting complaints from the patient. Well, why are you calling me? Because you have nothing to tell me. And I had to step out of work. I had to step out away from something. And your answer is, you don't have an answer for me. So I think I have to go back and listen. Triage does try to, I think it says business hours. I'll have to go back and listen to our phone. We do try to return messages within 24 hours. We do make it very clear that if this is an emergency, you do need to call 911. The same challenge you'll have when you walk into the clinic though is we can, if it needs a nurse to triage, we can get you a nurse to triage. But it's a nurse to triage. You won't be able usually to walk in and see your provider.
I did tell those people that I would ask the question at our public meeting, and then they could go to the recording of this meeting and hear what the answer was from you.
They can always contact the quality department too, which is where if they have an actual grievance or complaint, they really should go through Tony so that we can fully investigate and respond to them with their particular situation.
Well, I did tell them that there's some paperwork they could fill out.
Or call Tony on the phone.
Yeah. And then
Stacy's-
they get something else that you can talk about. I'm sorry, go ahead.
I just wanted, just like she highlighted the volumes on the fax numbers, do you recall how many phone calls are coming into FME?
The last time I was looking, it's about 400 to 600 phone calls a day
That's,
coming into just FME. And we have 3 to 4 people dedicated to answer phones and 1 to 2 people to respond to voicemails. And then the nurses, things that go to triage, we usually have about 2.5 nurses working the triage line and responding to triage requests from patients.
And while I-
Mondays can be 800 plus phone calls a day on a
Yes.
Monday. So Monday's always the highest. So when I talk in groups and people ask questions about answering phones, I always suggest to not call on Monday, only for Monday. Call Friday, call Tuesday, call Monday if you have to, but yeah, just a situational awareness of having a lot more volume on Monday.
Michelle, are you watching the draft?
and I'm also, it might be on in the background,
Okay.
but there's no.
Carry on.
I'd also just like to say, it's something that we saw quite often on, what's that?
No, go ahead. You cut out for a second, but you're fine.
Oh, I was
Carry
gonna
on.
say, we saw quite often on our Radar 8 surveys, we used to continually see comments about calls. And we are not seeing that anymore. When I do see those with information that really can be meaningful for Stacy, I send that way. And we've also instituted 5 additional questions that talk about their experience, being able to get time scheduled. And the good news here is that we're not seeing a trend like we used to see about call experience. So while I'm sure there are still everybody has their own experience and I don't want to discount that, we're definitely seeing improvement from where we've been.
Thank you.
Anything else?
No, but thank you for answering the question, because since this is a public recorded meeting, and I told them they could be able to listen to this meeting because it's being recorded. They can hear about the wonderful thing that you're talking about now, that their phone calls will be dealt with 100% the best they can.
What I hear is like that is just, you think you live in a small community, but it just seems like there's endless demands for services, for people to respond to the phone calls. I mean, it just seems like no matter what we do, we can't sort of keep up with it. I just don't know. Is a lot of that coming from outside the community because we've sort of brought people in here? Is it because we have an aging population? Our actual population of Kittitas County hasn't grown that much over last 8 years.
In a way it has. I mean, if you look at how many new patients we see in the clinic and the dashboard, those numbers hover between usually 800 to 1,000 new patients a month.
Yeah,
That's a lot of new volume.
right.
And yes, that covers all the clinics,
Yeah,
but there's a good chunk of that coming into family practice too.
okay. Is that, we're keeping more people with local, who would have previously gone out of the community to get their care is, because I mean, this is.
I
something
can
that-
I can do some zip code work for you.
Well, it's just really a curiosity thing because, like I say, when you look at the population, it hasn't really grown. Just the sort of official population of Ellensburg, Kittitas County. But yet, no matter, we offer new services, we have more people just specifically dedicated to the phones and everything, and we just can't seem to keep up. And I guess that's a sign of our success that we're keeping more people local. But anyway, I don't know, it's just sort of a puzzlement.
If you want another number to think about is how many appointments we actually do at Family Medicine of Ellensburg a day. A low volume for us is probably low 100s. We have days when we've got large teams there where we're over 200 people alone, 200 appointments a day. That's a lot of volume running through that.
Yeah, I mean, because I looked into these numbers not too long ago, and because people are talking about not being able to get appointments and things, and I say, look, compared to 5 years ago, even the number of people we see is just incredibly a lot more. So then, we're trying, we're seeing a lot more patients and getting a lot more new patients.
If you look at it for family practice, if you look at the dashboard, what I started adding on there now is really where the teams themselves are. In FME, you've got the orange team, the green team, and the blue team of where they are for the next third available for new patients and for existing patients. You've got that orange team up there is at 9 days out, but really green and blue is fairly low for next available. The challenge is my next available could be 3 p.m., which doesn't work with your schedule.
I don't know if we were ever meeting demand before those. I don't know if we've ever, so even though the population hasn't changed, we weren't meeting
Yeah.
the demands of that population to begin with.
I think accessibility too, so, patient portal, we get just as many messages as we do phone calls. Patient portal and messaging is a relatively new thing in the last 10 years, being able to communicate with your provider that way. And then same with access to the phone numbers as well. You don't have to go to a phone book to look up your doctor's office number anymore. It's at your fingertips. So convenience plays a lot into these calls. And realistically, I think we provide more care over messaging portal and phones than ideally we should, but we provide a lot of care that would otherwise be in-person visits and people coming in. It does bog down like this one. I think Dr. Thomas and Dr. Beard could allude to that. Of how much care we're providing remotely, because we know that they can't get in at 3 p.m. Tuesday in 2 weeks. And then we start.
Are you suggesting we change our phone number on a regular basis?
Convenience is a definite thing.
Yeah.
And just the information that people I want to answer right now, or call have this.
Make it a 1-900 number.
10 years ago.
It goes straight to the minute.
Yeah.
We've had rapid access, but
Race fun.
Yeah.
so you're complementing the service with rapid access. Their numbers are running into the 30s and low 40s for one provider to do in a 12-hour shift. So you've got those numbers going on, and I do view triage as opportunities lost. Those are patients who would have either walked into the clinic or made an appointment for the next day or two if we would have appointments available. We're running 3,000 triage calls a month for the entire organization, for all the clinics.
Well, see that, I mean, that's what I'm sort of talking about. I mean, I'm sympathetic, you know, when people can't get through or when they can't get, you know, an appointment as quickly as they want or something like that, but, after expressing sympathy very briefly. The second thing I show them is the numbers. It's like, geez, oh man, you know, this is how many calls we were getting a day 5 years ago. Now we're getting this many calls a day. This is how many appointments a day we were taking, you know, we were doing 5 years ago. This is how many we do now. It's like, we're trying to keep up. We've expanded, services and we've expanded, how many appointments, you know, how many patients we can take. Anyway, it's not from lack of trying, certainly. But we just can't keep up. Yeah. Anyway.
Maybe we'll come.
The parking lot's shoulder.
Yeah.
Yeah.
Anything else for Stacy, you made? No. Anything else for us?
No, thank you.
All right, thank you. So moving on to medical staff, we have acting chief of staff, Dr. Deere.
So our medical executive committee met on April 15th and reviewed a number of files for both initial appointment and then reappointment. There was a group of initial appointments that were primarily, we talked a little bit about the Compass telehealth a few minutes ago, about the pulmonology, cardiology, and infectious disease, and a number of those are requesting privileges that were approved by our group, are passed on to the board for approval. And then also the rural physician group is also has three people that are going to be rotating on our inpatient service and having them credentialed, and then also the Joe Reiner, who's our new PAC with the cardiology team. And so those are our initial appointments, and then we have reappointments with Dr. Larson on the inpatient service, and then the ONRAD team has a couple of people that we have passed on for approval as well. And then Aaron Long is with Compass Direct, and then Chelsea Newman is a reappointment with KVH Lab. So all of those we've reviewed and are recommended to the board for approval.
Excellent. So if there's no other questions, I'd entertain a motion to approve the convention.
I'll move to approve.
Same. So moved by Erica, second by Bob.
The only, sorry.
Oh, please, I can say.
The only thing I wanted to mention was, you know, John and I are in the NBC, and I'm not sure if the other board members realize just how much scrutiny you guys put into these liners. You do a whole lot of work to make sure all the I's are dotted, T's are crossed, and anyway, it's you know, it's one of those things where you don't see all, you know, you just see the tip of the iceberg here. But I know John and I really are impressed by how much work you guys do at NBC. So thank you.
Shannon does a lot of it in the background.
Yes.
Because a lot of it is collecting data from, you know, the practitioner data banks to licensing bureaus across the country, and particularly folks like the Compass Compass Telehealth, the Telemed, have licenses in a number of states, so we have to check and make sure that all of those are current and appropriate and no limitations on new activities. So there's a lot of kind of background checks that we do to make sure that we're bringing on people that are quality and don't have any restrictions.
Sure. Yep. Well, yeah, we really appreciate it.
Yeah, I would second what Matt said. It is really impressive to see you'll take an incoming provider and really get into the procedures they've done, talk about, you know, are they going to need proctoring? I mean, you just see how much thought goes into making sure this person is ready to do quality work at this facility safely for everyone. And again, it's always fascinating to just sit and listen to the discussion and learn all those behind the scenes. So I appreciate feeling welcomed at that meeting, just listen in. So yeah, so thanks, Matt, for bringing that up. Appreciate it. So we have a motion. We have a second. Any further discussion? Hearing none, I will, everybody in favor, say aye.
Aye.
I too will vote aye. Anybody opposed? That motion passes. Thank you, Dr. Bain. Anything else for that's all? Great. So next we have Chief Medical Officer, Dr. Thomas.
Thank you very much. My report begins on page 59. I have no substantive updates to make, but I will point out to the issue of access. one of the themes that runs throughout the work of all of our medical directors is interviewing for new applicants and opening new positions. So we're hoping that that helps to address the access needs.
Excellent. Any questions? I had one question about this is under the emergency services, open new transfer manager call line to be staffed by the ED to facilitate and coordinate transfers out of the entire hospital. So that's proving useful.
It's in operation. I'll highlight the work that Deb's team has done because they're the ones who have actually done the spearheading of the work.
Well, we're kind of in a trial stage right now, and you can speak to it if you would like. What we recognize in the work that we're trying to do with transports is that we have had not great communication across the organization to understand if we have a lower level of care, say in the ED that needs transport, we're communicating across. And so we've assigned that to the ED so that just for the local transports to ensure that if DJ's team gets called, we know that they're transporting the right patient because they start taking off across the pass. And now we actually have a patient who's sicker who needed to go ahead of that patient. So we put that in place. And actually that person is joining the call that I think Jason spoke to earlier, the daily call, so that we can start to increase our communication. And I'm hoping next month when I come back, I was going to talk more about creating a process where we are really looking at a transfer center model. So we're looking out across so that our partnerships understand what is our needs currently. So I feel like it's going well. Our teams are saying it's going well.
Yeah, it's been great. Again, the communication, that's one of the things I want to let the board know is that the team's been working really hard and with us to try and help figure this problem out. And again, we're in the trial stage of this. We're getting them on the call in the morning, but it's really early stages. It's working really well.
So just so I understand, so it's before individual organizations might just say, ship them out and not really coordinate to see if there's a higher priority. So, or is there, am I missing?
No, it was more us, actually.
I didn't
not
know
other
it was
organizations.
either, but okay.
Yeah.
I tried.
You can take the ownership. No, so let's say Med-Surg had a patient who we were gonna move to IC, but we were gonna transfer them out. They're too sick. And so Med-Surg would get the transfer.
They would arrange transport without checking
And
anybody
they
else.
may not let the ED know, and the house suit may or may not have been in the middle of that. They should have been, but maybe they didn't get called. So DJ had brought that to our attention, actually, so thank you, that was an issue throughout our system as far as communication. So we made it one point of communication, not only to make it more streamlined, but also so we can start collecting data, understand how much our transfers are going out, who's doing our transfers. And so it's really a data collection as well. So when you have one person doing it, then you can really manage it in real time.
So all transport in the county now would go through one entity to coordinate, or at least this part of the county, or
Yes, it's the local, it wouldn't be anything outside of our local transports because that could take time and the ED can't manage it.
what I'm saying, we don't send the ambulance unless it's gone through this person to say, at least for transport, to say,
Correct.
this is the smart one to do. It
It
takes,
did go through it, yes,
okay,
theoretically, we're in a trial, so we
Okay.
may have a
I'll
one.
come back to that. I'm,
And I will print, I'm waiting until I take it to the exec committee, but we are creating a huddle form and then a capacity huddle for the hospital. And when we do that process, we'll have better communication to know, is it happening, is it not happening? So it's really to help us streamline, but also collect information so that we know what we need to work on to be better, so that we're more efficient for these guys.
Just to illustrate the complexity of this, while Med-Surg and the emergency department may make their request through KitCom, as a newborn acute provider, if I'm transporting a baby out, I may make my request through Life Flight or Airlift Northwest, and their dispatcher may make the request to DJ's team for transport from the fixed wing landing side at the airport back to the hospital and back. So there's a lot of collaboration and coordination that's necessary.
We also don't want two helicopters coming at the same time. And we've been fortunate that it hasn't happened.
Well, it has.
Yeah.
Well, at least since I've been.
Last weekend,
Oh, it's, oh, I wasn't,
but I had staff, so we're good.
oh, okay.
oops.
Nothing, yeah, okay. Not that I had been reported, but, yeah, so that's the one.
Okay.
But it's kind of an evolution and this is just the first piece of it.
Fair enough. I
Big
appreciate
problem.
that, yeah. Anything else for us?
Nothing else to add.
Any other question? All right, thank you, Dr. Thomas. Moving on to CFO, Jennifer.
Good evening. I'm on page 61. I don't have really anything to add except to say that all of this great work we're hearing about tonight is transformed to your financials here. And I could just point out that year to date, we are $2.5 million stronger than last year at this time and $1.4 million ahead of our budget for this time this year. That's all due to cost containment, charge capture. So unless you have questions, I can stop there.
Any other questions on the? And like Matt had said, regarding MEC, Bob and I are on finance, and again, the work they do behind the scenes is really quite impressive. It's a strong team, and I always enjoy those discussions, and they will go as thorough as we ask for to get into the weeds and stuff. So thank you for that. But yeah, carry on. Anything else?
Not unless you have questions.
So if there's no other questions on the financials, then we will move to community relations.
I've got one.
Oh, there we go.
Sorry.
Didn't leave long enough gap. Go ahead.
Oh, sorry, just a heads up. So we are doing a request for qualifications for architectural and engineering services for Radio Health.
Services that it kept saying.
Yeah, request for qualifications for architectural and engineering services for a Radio Hill project. So we're not bringing that project yet forward to the board for approval for any renovation or construction. We are just seeking an architect to help us with the design work, estimating, and then to bring it to the board to move forward or not move forward with that project.
So the step you're at, you don't need board approval. You're just advising us.
I think a motion authorizing us to do this RFQ would be helpful.
Would you like that now or at the end of your discussion?
Let me give you a little bit more about it. So the SAO, or State Accountability Audit, every 2 years they audit. So this has always been one where they suggest there's some room for improvement in our procurement practices to ensure that we are getting competitive architectural and engineering firms into our facility and not just picking one always type of a thing. So we're going through this RFQ process in as a result from the SAO to just do a little better on that. It's never been a finding from the SAO. It's always been a feedback that we can do a little bit better on. So we are going through new territory through it, and Jennifer also created a new policy on improving architectural engineering services. So we're trying to dot all those I's and T's that it takes for being a public entity. That's all I have done.
And just for me, you have some experience in this area too. It sounded like when we were talking, so it's nice to have you bring your thoughts to the process.
I have experience with the SAO, that's for sure. Yeah, so we're just trying to shore those up and make sure what we're doing is documented, so.
If anyone is so inclined, I'll entertain a motion for the RFQ they'd like to do.
Motion.
Motion by Matt. I think it was Erica first. Yeah. Any further discussion? All in favor of giving them authority to create an RFQ for this project? Say aye.
Aye.
I too will vote aye. Any noes? Hearing none, that motion passes.
You didn't forget. That was full credit to Mandy for the reminder.
Was she texting you or giving you the high sign?
It's showing up.
We did that.
Thank you, Andy, for taking us on track. So, Michelle, Chief PR Officer, what do you have for us tonight other than the draft? Who did the Seahawks get? Never mind, carry on. Can you hear us? Michelle, you can go ahead.
Well, this is an interesting night because it's the first time I've had a little connectivity issues, so I apologize for any of that. I do feel like it's important, even though you see things on in the background. One of the reasons that I'm not there in person is immediately after this meeting, we start putting together what's called the KVH huddle. And it's a monthly publication that we send to the staff. So while this meeting is happening, I'm actually sitting at my computer and putting in the updates that are coming from this meeting and what everybody is reporting. So just thought I would share that with you. Outside of that, I don't have anything new to add from the report, but I would be happy to take any questions.
Any questions for Michelle?
I would like to say I really appreciate the huddle. I like how you capture the meeting and get that out to staff. I think it's a great way to be transparent and include everybody. And I think that's that job really well done.
Thank you. I'll pass that along to my team.
Anybody else? Thank you, Michelle.
Of
Appreciate
course.
it. Okay. All right, so that concludes that section of the meeting, and this is a point where often we take a minute or two break for anybody who's had enough for tonight, to go home, see your families, get some dinner and so forth. We will just continue with executive session. Let's see, it is 6:50, so we'll take a 5-minute break, and at 6:55, we'll start executive session. How long do we need tonight?
15 minutes?
Is there any action anticipated after the meeting?
Yes.
Okay,
Possible.
possibly some action. So,
Do you think we can handle what we need?
we might want to give it 20 minutes then, okay, because we can extend if need be. We're going to do, at 6:55, we'll do a 20-minute executive session. We anticipate possibly some action afterwards when we come back to public session, but no votes will be taken in the executive meeting. So, all right, so thank you, everybody. We'll take a little 5-minute break, and then we'll start executive session.
Thank you.
Thank you.
Great, no, I didn't.